Welcome to Pharmacology module, Adrenergic Bronchodilators, and in this module we do have a defined set of outcomes, and we will look at differentiating between short-acting and long-acting beta-agonist type drugs, understanding the modes of action, drug duration, and order frequency associated with these types of drugs, identify the different types of aerosol delivery devices, differentiate between rescue inhalers versus maintenance inhalers, and understand the benefits and potential adverse side effects of newer beta agonists. Looking at a quick review of how these adrenergic bronchodilators work, also known as sympathomimetics, they basically work by relaxing contractions of the smooth muscle of the bronchioles. We typically refer to these agents as beta agonists. Beta agonist type bronchodilators can be classified as short-acting or long-acting in terms of duration and onset of action. The small chart here on the bottom right of this slide basically indicates changes in your forced expiratory volume 1 second with the different types of bronchodilators employed. In this case, Xopenex and Racemic Albuterol and a placebo. And you can see that within the first hour there's a significant increase in your FEV1, and then that tends to taper off over time. Typical diseases that benefit from beta agonist type drugs include COPD, emphysema, bronchitis, bronchiectasis, and acute or chronic asthma. And as we look at this chart below, this is basically a schematic of how the beta agonists actually work within the lung itself. And the net result of beta-2 receptor agonism in the lungs is relaxation of the bronchial and tracheal smooth muscles, which in turn relieves bronchospasm, reduces airway resistance, facilitates mucus drainage, and increases vital capacity. And you can see from the chart at the bottom that the primary mechanism for bronchodilation is the conversion of ATP via adenyl cyclase, which converts to 3,5-cyclic AMP, which is the membrane-bound chemical which is responsible for bronchodilation. Now as we move on to the next slide, this slide again goes through the pathway, and I'll sum it up on the slide. And basically what you see is that your beta sympathomimetic attaches to a surface receptor of a cell, and the enzyme adenyl cyclase, as we looked at in the last slide, the stimulation of adenyl cyclase results in the conversion of ATP to 3,5-cyclic AMP. And it is the level of membrane-bound 3,5-cyclic AMP which is what is responsible for the relaxation of bronchial smooth muscle. When you stimulate 3,5-cyclic AMP, it also results in the inhibition of mast cell degranulation, which releases histamine, causing bronchoconstriction and mucosal edema. So these beta adrenergic drugs primarily work by stimulating the production of 3,5-cyclic AMP, which then is the membrane-bound bronchodilator chemical. And it also serves to inhibit the release of histamine, which is responsible for bronchoconstriction and further mucosal edema. And sympathomimetic bronchodilators, they are the most popular class of drug agents that are administered by respiratory therapists. And these drugs were developed from drugs activating both alpha and beta receptor sites, which we'll review in a later slide, to very specific beta-2 stimulants, achieving bronchodilation with minimal or no cardiovascular or CNS effects. The goal is to deliver a drug that is beta-2 specific without the adverse side effects related to the sympathetic bronchodilators. Our early sympathomimetic agents were used primarily in the treatment of asthma, and drugs such as Epinephrine, Isoproterenol, Isoetharine, Ephedrine, and Racemic epinephrine were all used to treat asthma. Ephedrine, for example, is extremely old in terms of use as a bronchodilator, dating back to the Chinese herb Ma Wang. With the development of newer bronchodilator agents, what we see today are less side effects and longer duration of action, both very desired effects when we talk about delivering medication. And so the goal of bronchodilators should be to achieve maximum bronchodilation with the least amount of side effects. For example, epinephrine is the strongest bronchodilator. However, its administration can result in some severe cardiovascular effects if over-administered. This is why it's not a first-line drug of choice for the treatment of bronchospasm in patients who are having difficulty breathing. Sympathomimetic amines, or better known as catecholamines, they all mimic the actions of epinephrine more or less precisely. And what will occur sometimes is that you may get undesirable side effects such as tachycardia, elevated blood pressure, smooth muscle relaxation of the bronchioles, and skeletal muscle blood vessels and skeletal muscle tremor. Respiratory therapists primarily deliver the majority of their sympathomimetic agents via aerosol route, which typically results in less side effects because the point of contact is the lung, and you reduce the systemic side effects by delivering via the lung. Now, as we review, we need to look at short-acting versus long-acting type beta-agonist drugs. And short-acting beta-agonist drugs are used for acute relief, referred to as rescue inhalers. Drugs such as Albuterol and Levalbuterol would be good examples of short-acting beta-agonists for acute attacks. And long-acting beta-2 agonists are used for maintenance bronchodilation and bronchospasm control. Drugs such as Salmeterol and Formoterol are both good examples of long-acting beta-agonist drugs. We can further break that dosage up in between ultra-short-acting, which is less than 3 hours duration, like epinephrine, Isoproterenol, and Isoetharine, and short-acting 4 to 6 hours duration, which would be Metaproterenol, Terbutaline, Albuterol, Pirbuterol, and Levalbuterol, and long-acting 12 hours duration, Salmeterol and Formoterol. So the type of drug that we choose to employ is also depend on the therapeutic objective, whether we're looking for a longer duration or a shorter duration of therapeutic activity. Now, there are two basic types of receptors that it's very important for you to understand, and the beta receptors are actually broken into two subclasses. But let's look at the alpha receptors for a second, and you'll see that the alpha receptors are associated with peripheral vasoconstriction and excite receptors. So when medications stimulate alpha receptors, the response within the body is vasoconstriction. Obviously, that would not be a desired effect if we were looking to cause bronchodilation in the lung. We would want a drug that would have no alpha and have more of the beta effect. The beta receptors are broken into two classes: beta 1 receptors, which stimulate receptors in the cardiac smooth muscle, so we can think about the heart when we think of beta 1, and that results in an increase in heart rate, which is known as a positive chronotropic effect, and an increase in the force of cardiac contraction, which is known as a positive inotropic effect. When we deliver a bronchodilator, we would like it to have a minimal amount of beta 1 activity. In other words, we would not want it to have an increase in heart rate or an increase in heart force as a side effect of the bronchodilator drug. So when we deliver bronchodilators, our targeted receptor is really the beta 2 receptor, which relaxes bronchial smooth muscle and vascular beds of the skeletal muscle and causes bronchodilation or vasodilation effects. You will see that as we review the drugs, that over time the drug manufacturers have been able to refine bronchodilators, beta adrenergic drugs, to have the lowest amount or minimum amount of beta 1 receptor activity and a higher amount of beta 2 receptor activity, and that actually is the goal in terms of creating bronchodilation. Okay, let's begin our review of beta agonist drugs with epinephrine, also known as adrenaline, and I've included pictures on the slide so that if you see these drugs, you'll be able to recognize them. Epinephrine is used as a bronchodilator because of its beta effects on the bronchi, and it's also because of its pharmacological antagonism of histamine. We typically use it to treat acute attacks of bronchospasm associated with emphysema, bronchitis, asthma, or anaphylaxis. It's typically administered via sub-Q when used for treating severe bronchospasms, and it's rarely, if ever, administered by the aerosol route. It comes in a 1%, 10 milligrams per milliliter solution. And the unique thing about epinephrine that you want to remember is that epinephrine stimulates alpha, beta 1, and beta 2 receptors, all three receptors. And we usually only administer it sub-Q for severe status asthmaticus, and we do that for the beta 2 reception. It's also used as a cardiac stimulant to increase the heart's contractility in a beta 1 situation. And it's also used to control bleeding for its alpha effects. You may see that in preparations with lidocaine. The side effects include an increase in the heart rate and force, and increase in myocardial oxygen consumption. This makes epinephrine a fairly complex compound because of its alpha, beta 1, and beta 2 stimulation. Therefore, it's typically not used as a first line of treatment in bronchodilation for patients who are suffering from bronchospasm. Okay, our next drug is racemic epinephrine, and it's also known as micronephrine or vapornephrine, and it is a synthetic form of epinephrine, and it comes in a common strength of 2.25% or 22.5 milligrams per milliliter. The typical aerosolized dosage is 0.25 to 0.5 cc's mixed with normal saline. And its mode of action is similar to epinephrine, except that it results in about 1/2 of the vasopressor effect of epinephrine. We typically use vapornephrine for post-extubation for someone who has either croup or subglottic edema, and that is typically due to upper respiratory mucosal edema. We will give an aerosol treatment with vapornephrine to reduce the stridor. The next beta agonist drug that we review is Isoproterenol, also known as Isoproterenol, and it comes in a 1 to 200 or 0.5% milligrams per milliliters. Its dosage is between 0.25 and 0.5 cc's with 3 cc's normal saline. And it is a powerful beta 1 and beta 2 stimulant. It has rapid onset and it has short duration. Isoproterenol is typically not used today to cause bronchodilation as a therapeutic modality, primarily because of the powerful beta 1 stimulation, and the adverse cardiovascular side effects make this a very poor drug of choice as a maintenance bronchodilator. Typical effects such as tachycardia, palpitations, and increased myocardial oxygen consumption are all associated with this drug. So although it's a very powerful bronchodilator, its ability as an effective bronchodilator is limited because of the side effects associated with Isoproterenol. Our next beta adrenergic drug is Isoetharine, also known as Bronchosol, and Isoetharine comes in a strength of 1%, 10 milligrams per milliliter, and the dosage is usually 0.25 to 0.5 cc's of solution, again mixed with 3 cc's of normal saline. It's primarily a beta 2 stimulant with minimal cardiovascular side effects, beta 1. Its duration is only about 1.5 to 3 hours. Now, Bronchosol is what I would classify as an older beta agonist drug. It's no longer marketed in providing aerosol treatments, and you would not typically see this drug or utilize this drug today because of the newer and more efficient drugs that are primarily beta 2 stimulants. Now, I made a note here because we are going to be talking about MDIs, and it's important for you to understand that chlorofluorocarbons, or CFCs, they were the propellant traditionally used in MDIs, and they have been classified as ozone-depleting substances, ODSs, and the FDA has mandated that by 12/31/08, all single-ingredient products containing CFCs as propellants will no longer be permitted to be produced, sold, or marketed in the United States. So what that means is that many of these MDIs that you will either see as pictured in your books or in older literature will no longer be produced because the CFCs will be illegal as of 12/31/08. In response to that, the companies have developed a propellant known as hydrofluoroalkanes, HFAs, in place of the CFCs. So you will see that the MDIs you'll be working with, many of them have already been converted over to HFA propellant, and the CFCs are no longer available. Our next drug then is Metaproterenol sulfate, also known as Albuterol. Again, relatively older in terms of its usage, and you can see up here that we have a MDI of Albuterol, and down in the right corner here we have the Albuterol unit doses. And Albuterol comes in a 5% solution, or 50 milligrams per milliliter, and the dosage was less, 0.2 to 0.3, and it lasted longer than other previously mentioned drugs, up to about 4 hours in duration. However, Albuterol was notorious for having more cardiovascular side effects because it is a sister drug to Isoproterenol. So it's available as an MDI, but it's rarely, if ever, used for medication nebulizer treatments any longer. I believe that the company is working on an HFA preparation of Albuterol as well. Okay, our next drug is Terbutaline sulfate. It also is known as Bricanol or Brethine, and it comes in a 0.1% strength. It's a 1 milligram ampule. Its aerosolized dosage is between 0.75 and 2.5 milligrams in 3 cc's of solution. It's usually administered sub-Q, aerosolized, available in MDI, or available as a tablet. It's relatively long-acting, 4 to 6 hours, with less cardiac side effects of either Isoproterenol or Albuterol. And it's also used to treat premature contractions of labor and stimulates increased mucociliary activity. Again, this is one that you would rarely utilize, primarily because the newer bronchodilators are much more efficient at beta-2 stimulation. And you can see from the photos that there's an MDI. These are the ampules that typically Terbutaline was packaged in, and these are the actual tablets that would give you bronchodilation via oral route. Now we move on to Albuterol, which is also known as Ventolin, or Salmeterol, and it's available in unit dose of 0.83% and as an MDI. And this is by far still the most commonly used bronchodilator for medication aerosol therapy today. And you can see down here we have the unit dose, and over here we have a generic form of the Albuterol inhaler. Now, what makes Albuterol so desirable is that it is a selective beta-2 stimulant with longer action, up to 6 hours, and the key is virtually no beta-1 activity. So here's a drug that, for the most part, stimulates bronchodilation that has little to no cardiac side effects. The common dosage is 0.5 cc's, or the 2.5 milligrams in 3 cc's of normal saline. And you can see that it comes in a variety of sources. I've listed some pictures here so that you can see the different sources. But it can be given via inhalation aerosol, solution. There's capsules. And also it has sustained and released tablets and as a syrup. Now down here on the right here this is the Pirbuterol HFA. This is the new MDI. And also on the top here, this is Ventolin HFA. The same drug, different packaging, different manufacturers. And in the middle here, this is Duoneb. One of the most common things you'll see is Albuterol is mixed with a anticholinergic drug, such as Atrovent, and combined, and you have what's called Duoneb. So you have Ventolin HFA, you have Ventolin HFA, and you also have Duoneb. The next drug is Betalotrol. It's also known as Tornilate, and it was known as a prodrug because it must be converted by the body for activation. It was administered via MDI, 1 to 2 puffs every 4 to 6 hours. However, Tornilate was withdrawn from the U.S. market in 2001, so it's no longer available in the United States. The next drug is an inhaler. It's known as Pirbuterol, and it's better known as Advair. And this was given 1 to 2 puffs every 4 to 6 hours. It's administered only by MDI, 0.2 milligrams per puff, and it is a non-catecholamine adrenergic agent. Now, up on the top corner here is the older MDI when it had a CFC propellant. This one here, you will no longer find this one. It is no longer marketed. And now you have what's known as the auto inhaler, which is the one on the bottom here. And this is referred to as a breath-actuated inhaler. So there's no need for a spacer or a chamber to utilize this inhaler. And what the breath-actuated inhaler does is it delivers the medication automatically without the need for the patient to coordinate actuation with inspiration. So one of the questions you might be asking yourself at this point in the module is, why would a physician order either Maxair inhaler versus a Pirbuterol inhaler? Well, much of it depends on physician choice and depends on the literature review and which one they think may be more effective for treating their patients. Okay, the next drug is Salmeterol, and it's also known as Ceravent. So now we're starting to move away from the rescue type inhalers and rescue type drugs, and we're looking more at a maintenance type drug. And you can see from the first bullet that this has a slower onset and a longer duration of other previously mentioned drugs. You can see here that it's available as an MDI, and it's also available as a discus inhaler. And it's not to be administered for use as immediate bronchodilator. In other words, this is not utilized for your acute bronchoconstriction situations. It does result in smooth muscle dilation and exhibits anti-inflammatory effects as well. This is what we refer to as a maintenance drug, and it's taken usually every 12 hours, one puff via MDI. So that's twice a day for the administration of this drug, not to be used in a rescue type situation where someone has an acute bronchospasm. And I've pulled out some information primarily from the packaging to re-emphasize that Salmeterol or Ceravent is not to be used as a rescue inhaler. You'll see that studies show Salmeterol to be at least 50 times more selective for beta-2 adrenergic receptors than Albuterol. And it's a long-acting beta-2 agonist, and therefore it is not used as a primary source of treatment for controlling asthma. It is a secondary intervention for maintenance of preventing asthmatic bronchospasm. And it's important to know that if you utilize Ceravent for the treatment of acutely deteriorating asthma, it can result in serious situation and even potentially life-threatening conditions. So although we have beta agonist drugs that can help individuals, if you employ them in the wrong conditions, they can actually cause death in some situations. There are documented cases where patients who were in acute bronchospasm grabbed an inhaler, or a family member grabbed an inhaler and grabbed an inhaler such as Salmeterol instead of something like Albuterol. And that can be very dangerous. And so there is a move by some of the pharma agencies to clearly indicate which type of inhalers are rescue inhalers and which type of inhalers are maintenance type inhalers, because patients sometimes are not educated in the different types of inhalers as well as their families. Now, Salmeterol is also the beta agonist found in the very popular product known as Advair. It is the purple packaged product that you'll commonly see and you'll commonly deliver in the clinical setting. And Advair is actually a combination of two drugs, fluticasone, which is a corticosteroid, and Salmeterol. So you get the benefit of both anti-inflammatory activity and bronchodilation. And Advair is packaged in 3 different formulations, 100, 250, and 500, although you'll see that it's 50 in all cases. You're only getting 50 of Salmeterol, and what's actually changing is the amount of corticosteroid is actually being increased. Because Advair contains Salmeterol, again, you would only give this twice a day, every 12 hours as far as its frequency. If you were to give Advair on an increased basis, it can be dangerous because of the strong beta agonist activity that could occur. Okay, the next drug is Levalbuterol, and this is also known as Xopenex. This is one of the newer beta agonist drugs that are on the market, And you can see up here, this is the label, and it does come in a solution form. And this is basically the R isomer of racemic albuterol, which is the traditional albuterol that I just covered. And we'll look at a graph here in a second to explain this a little more in detail. But if you look at, chemically, if you look at racemic albuterol, you'll see that there are two basic isomers, an R and an S isomer. And it's the R isomer that is primarily responsible for the bronchodilation, and the S isomer appears to be devoid of any therapeutic actions. So what this company has done is been able to isolate the R isomer from racemic albuterol and manufacture that. Now, levalbuterol has approximately a twofold greater binding affinity than racemic albuterol, and approximately 100-fold greater binding affinity than S-albuterol for beta-adrenergic receptors. So the claim is that levalbuterol, or Xopenex, is a much more beta-specific drug with less of the side effects that could be potentially caused by the S isomer. And levalbuterol can also inhibit the degranulation and subsequent release of inflammatory autocoids from mast cells. Okay, so levalbuterol Xopenex sounds great, and if we look at the chemical structures, you can see on the left is the S isomer, and on the right is the R isomer, which is levalbuterol. And if we read this short excerpt here, albuterol is a selective beta-2 agonist that is widely used in the prevention and treatment of reactive airway disease. It's formulated as a racemic mixture containing equal parts of the R and S isomers. The therapeutic activity of albuterol is due entirely to the R isomer, which I covered already, whereas the S isomer may actually have detrimental effects. So we seem to have a product that is more refined, is in one sense more beta-2 specific, and has removed the S isomer, which could have some detrimental side effects. And the question is, why is this not used, or why is it not replacing racemic albuterol? And part of the answer is cost, and still a number of studies to validate whether or not Xopenex is actually better than racemic albuterol. So levalbuterol, you'll see below, I've included what the packaging looks like. And you'll see that it's available both in solution and in the new HFA MDI. And we have three different dosages for solution. We have a 0.31 milligrams, we have a 0.63, and a 1.25. I do not have a picture of the 0.31, but the 0.31 is a green label, primarily indicated for pediatric use. And Xopenex claims faster action with a duration up to 5 to 6 hours. And again, it's available as an MDI HFA. Now, part of the requirements of this module will be that you will be required to read an article that I have attached, and it will deal with the cost effectiveness, a comparative study between levalbuterol and racemic albuterol, and determine whether or not, from the literature, the use of levalbuterol exceeds that of racemic albuterol. In addition, a number of your test questions that will come from this module will be based on some of the article review that you do as well. In conclusion for Xopenex, one of the things that the manufacturer's claims, and some of the studies do support, that although Xopenex is more expensive than racemic albuterol, the claim is that a patient would not need as many treatments because of the refinement of the beta agonist drug and the reduction in side effects that could be caused by the S isomer of racemic albuterol. Okay, and then the last one we have is Formoterol, also known as Formoterol, and you can see that this one's fairly unique. It comes in its own unique packaging, and it is actually a powder-filled capsule, and you would actually take the capsule out of the foil and place it in this chamber. And if you look at these two little blue switches on either side, once you put the capsule into the chamber, you puncture that. And if you looked inside the chamber, you would see there's fine stainless steel-like projections that actually puncture the capsule and allow it to be inhaled by mouth using this special inhaler. This again is similar to Salmeterol. It is a long-acting beta agonist type drug. It is not to be used as a rescue medication. Its dosage would be 1 capsule by inhalation every 12 hours as well. Okay, this concludes the review of beta agonist drugs. However, there are 2 other required parts to the module, and that is module readings. There are 2 module readings that you must complete, and they are the cost effectiveness of Levalbuterol versus Racemic Albuterol, and asthma treatment guidelines and use of inhalers. Both of these articles can be found in the journal folder on the Bank of Lab computers. Once you have finished reading the articles and have reviewed the module a couple times, you can then go to the online module review course in Blackboard, and you can attempt to take the exam on beta agonist drugs. It is required that you get a minimum of 85% on the beta agonist drugs exam. You can, however, take that exam as many times as you need to until you achieve that. So this completes the module review on beta agonist drugs. Welcome to Pharmacology module.